All right, well, good morning. Good to see all of you again. This week, we're going to talk about gait dysfunction in children with CP. Okay, let's see, we're not advancing here. Here are my disclosures. What we'll do in the next minute's time that we have together is consider how gait, well, the pathophysiology, really, if you will, of gait disruption in children with CP. I'll share with you a classification scheme for gait deviations, and then we'll look at some of the most common gait patterns that we see in kids with CP. As always, I'm happy for you to interrupt me at any point for clarification or to take a deeper dive. So let's begin with a definition. The modern definition of CP goes back to the end of World War II with the founding of the American Academy of Cerebral Palsy and Developmental Medicine. This definition has been modified over the years, and the last significant modification was in 2007. And I would imagine there'll be another one in the next few years, primarily because of the impact of genomic analysis in children with CP. Anyway, our classic definition of CP is that it describes a group of disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. As orthopedic surgeons, it's important that we recognize that the motor disorders of CP are often accompanied by other significant problems related to disturbances of sensation, cognition, communication, perception, behavior, and seizures. CP may be the consequence of an insult to a normal central nervous system. Examples would be infection, ischemia, or contusion that occur in utero. With the advent of brain imaging, particularly MRI, it's clear that there are some cases of CP where the cause is an abnormal central nervous system structure. And the group of disorders that we understand the best in this category are the neuronal migration disorders. On the right is an MRI of a child who is clearly missing a part of the brain. And that's not because of a trauma, but rather a genetic misfire. And this is called open-lipped schizencephaly. In resource-rich settings, the clinical reality is that while we are frequently able to identify risk factors, in over half the cases, we really can't find a specific cause for the CP. And that is always an issue for families at the front end who are looking for an explanation. Why did this happen? For as long as we've been accurately measuring the prevalence of CP, which is over 50 years now, we believe that it's 1 to 7 per thousand live births worldwide and 2 to 3 per thousand in resource-rich settings. What's interesting is that this rate has remained constant over all the years that we've been measuring it. And this is the consequence of offsetting consequences of improvement. So for instance, thanks to improved pre and perinatal care, fewer children are damaged at birth. So that would decrease the amount of CP. However, in the 60s, we developed the technologies for neonatal intensive care units. And children who previously would have not survived do survive. And a very small number of them, less than 5% of preemies, will go on to have CP. So that increases the amount of CP. As a consequence of this shift in etiology, the clinical profile has changed from the classic descriptions of CP, and we'll talk about that in a moment. But really, the take-home message for all of you is that there isn't one thing cerebral palsy. It's really an umbrella term. It's a collection of disorders, and should really be considered in the plural, the cerebral palsies. Now, when we talked about normal gait last week, we recognized that there was a control system, the central nervous system. There was a motor system, the muscles, and these muscles operated around a structural system, the skeleton. Let's consider how each of these are disrupted in kids with CP. Let's begin with the control system. In children who have had an injury to their brain, the clinical profile is related to the location and the severity of the injury. And it turns out that the central nervous system is quite plastic and has the ability to repair and recover. And this is certainly true in the first years of life. And there's even some evidence that in the teenage years that there's significant plasticity. To your right here is an MRI of a child born prematurely. And here in the first MR, shortly after birth, there's evidence of bleeding in the periventricular tissues. Follow-up MRI shows characteristic lesions in the white matter, which is called periventricular leukomalacia. And this finding is pathognomonic for cerebral palsy associated with premature birth, PVL. Now, for our purposes, it's helpful to divide the central nervous system up into 3 levels. The highest level is the pyramidal system. This is the home of voluntary motor control. Next is the extrapyramidal system. This is the home of automatic motor control. And finally, we have the spinal cord, which is the home of postural and locomotive reflexes. These are hardwired motor synergies that are present in all of us at birth. With maturation of the central nervous system, it becomes possible to take apart these hardwired motor synergies and repackage them to create new complex motor activities. With continued development of the central nervous system, there is selective inhibition from the highest levels of the CNS functioning at the level of the spinal cord. With further maturation, it becomes possible to learn new complex motor patterns, store them, and call them up instantly. And we've all had life experience with this. If you consider how you learn, let's say, to serve a tennis ball, you break the serve up into its component parts. You practice each part individually. You then practice putting all of the parts together in proper sequence. And then finally, once you've mastered the serve, you don't have to think about it in that detail at all. You can call it up straight away. So that's an example of learning a complex motor pattern and then storing it for use. In children with CP, it's helpful to think about how these connections between the different levels of the central nervous system are disrupted. For example, disruption of selective inhibition results in motor overflow and co-activation of muscle activations. It is more difficult for children with CP to learn new complex motor skills, and physical therapists have recognized this for a long time and frequently work with children to find alternative ways of wiring or programming the central nervous system to achieve new motor activities. So let's consider how motor control is impacted in kids with CP. Children with CP have diminished selective motor control. This refers to the ability to isolate the activation of a particular muscle group, to control the timing of that activation, and to prevent overflow activation of other muscle groups that are close by anatomically and neurologically. Children with CP have persistent primitive reflexes. These are those hardwired motor synergies that exist at the level of the spinal cord that I was talking to you about. And they may have disruption of the agonist-antagonist relationship. If our target or reference muscle is considered to be an agonist, the muscle that does the opposite thing is the antagonist. And when we activate an agonist, there is a reflex loop at the level of the spinal cord to block the activation of the antagonist. Otherwise, if they were firing at the same time, we would not be able to achieve any movement. Several of these points are shown in this orthopedic examination called the confusion test. This is a child with bilateral CP, and in the screen to your image to your left, we're asking the child to dorsiflex their ankle, and you see that they're not able to do so. Does that mean there's something wrong with the ankle dorsiflexor muscles? Well, in the image to the right, we're asking them to flex their hip against resistance. Hip flexion and ankle dorsiflexion are coupled, and we see that, yeah, they're dorsiflexing their ankle. So this test shows us that there, at least initially, there's not any problem with the muscle tendon unit. It's all about how that muscle is controlled. Children with CP have disrupted motor tone. The term that we use to describe this is spasticity. As I mentioned last week, this is a term borrowed from adult neurology and doesn't perfectly capture what we're dealing with. But for our purposes, we can consider spasticity to be an exaggerated response to a fast stretch. We'll come back to that. Children with CP may have disrupted balance and body position sense. This is thought to be due to lesions of the extrapyramidal tract. And it's pretty clear that children with CP have delayed maturation of the central nervous system. For this reason, we don't want to do any aggressive, irreversible interventions until the child has achieved what they're going to achieve on their own. And one of the clinical truisms in CP is what you have by age 7 relative to motor function is what you're going to have. And I've certainly seen cases that have disproven that, but as a group, that seems a reasonable thing to remember. And as a consequence, most of our aggressive orthopedic surgeries, we try to hold off until 7 or older. There are multiple classification schemes for CP. Historically, they were based on etiology, but I've already told you that the etiology has changed over the years, and frequently we don't know the cause of CP. So that's not a very helpful classification scheme. With the advent of brain imaging, and in the future, perhaps more biologically based brain imaging, there are classifications based on the pathoanatomy of the central nervous system. I think we're not too far away from being able to recognize certain injury patterns of the central nervous system and make fairly accurate predictions about the clinical phenotype to follow. However, in our day-to-day practices, most of the classification schemes for kids with CP are based on the clinical phenotype or profile. We use terms borrowed from adult neurology to describe peripheral motor impairment. And again, these terms are not perfectly specific to the disease process that we're dealing with. A very common classification scheme that we use is called the geographic or topographic classification. This describes which part of the body is affected. So somebody who has only one extremity affected might be a monoplegic. If you have ipsilateral, same side, upper and lower extremity, you would be considered a unilateral or hemiplegic. If you have both lower extremities involved, you would be considered a diplegic. And if you have all of your extremities involved, we call that total body involvement. This is a remarkably inaccurate description or classification scheme. Every research project I've done where we've looked in the chart on a patient's history, the descriptions and classifications can vary from visit to visit. So not very precise. Now, for our purposes relative to gait, it's helpful to consider 4 types of CP. The first is the spastic type. As the subject goes from point A to point B, they have a fast stretch and a spastic response of the muscle. However, their balance is good, their motor control is good, and they can get back on track. So as they go from point A to point B, it might look like that. And here's an example of a child with spastic CP. She has what we'll learn is a jump gait pattern, but you can see that she's able to stop and start and turn and has pretty good velocity going down the runway here. This is the type of patient that the orthopedic surgeon is the happiest to meet, okay? Our orthopedic interventions are the most reliable and predictable in children who have spasticity. The second type is the dyskinetic athetoid. I'm using dyskinetic here simply to mean abnormal movement. Athetoid refers to impaired motor control resulting in motor overflow. So as the subject goes from point A to point B, they follow a very circuitous, somewhat nonsensical route. In the extreme, the child can look like they're intoxicated, and that creates some social issues when these kids are out in the world. When watching a child walk, look at their face, their hands, fingers, feet, and toes. And that can give you a clue whether you are dealing with a dyskinetic athetoid type. So this boy is not playing around here. He can't control his motor function. Every stride is a little bit different. Those facial movements, the hands, the feet, all of that is part of his underlying disorder. When you see somebody like this as an orthopedic surgeon, you have to be very cautious. The outcomes of our soft tissue surgeries have been quite unpredictable, and we've unfortunately made people worse with those surgeries. We generally try to focus on skeletal surgeries in this group related to deviations that are consistent stride to stride. That's a much safer way to approach these kids surgically. So dyskinetic athetoid. The third type is the dyskinetic ataxic. These children have impaired balance and body position sense. As a consequence, when they walk from point A to point B, they try to keep all of their limb segments tight together in the midline, and their path would look like this. There are other clues that you're dealing with this. If you are examining a child on the table and they seem to be ill at ease or uncomfortable, it may be because they don't know where the edge of the table is relative to their body. So that's a clue that you may be dealing with somebody who has an ataxic type of CP. So this boy is using a 4-point crutch gait for balance. When he sits down, you will see that he has to back up until his legs are touching the chair to get some sensory input. He has to put his hand on the chair, and then he has to actually look and see where the chair is. What he's doing is trying to get all the sensory input he can to make up for the fact that he doesn't really know where his body position is in space. When these children walk, you will frequently hear a slap of their foot against the floor. What they're doing is trying to get auditory input. And many of these children like to keep their joints in end range. That means fully extended, perhaps, to improve proprioceptive feedback by stretching joint capsules and ligaments. This is another group where we have to be very cautious in the surgeries, orthopedic surgeries that we offer, because many of these deviations are not related to muscles that are too tight or overactive, or even skeletal malalignments. So I told you there were 4. I've described 3. The 4th may actually be the most common, and that's the mixed pattern. The more sophisticated you get with your examination, the more of these findings that you will see. And so we frequently end up saying, well, this patient is primarily spastic, but has a small athetoid component, for example. And as I mentioned earlier, there are non-gait clues. How do they start? How do they stop? How do they turn? How do they get up out of the chair or off the floor? And how are they when you examine them on the plinth? So here's a child who's got it all. On her left side, a very consistent plantar flexion knee extension couple, suggesting tightness of the plantar flexors. Notice there was motor overflow. She can't really stop on a dime. She's a wide turn and stop. She starts, she stops again motor overflow. She falls down, and you have a sense that she doesn't really know where the floor is relative to her body. So again, this is a very complex type movement disorder. And as orthopedic surgeons, we have to approach them with great caution And again, try to look for deviations that are consistent stride to stride, that are related more to skeletal problems than soft tissue problems. All of you are or will be, by the end of your time here, familiar with the gross motor function classification system for cerebral palsy, GMFCS. This has been probably the biggest advance in the course of my career in the management of CP. It has really helped us understand prognosis, it's guided decision-making, and helped us sort out outcomes. We recognize 5 levels, and the higher the number, the greater the degree of motor impairment. The levels 1 and 2, the most functional groups, have very similar problems. And again, our interventions with the right patient, the right data, the right decision-making, the right surgery, the right post-op management, the results are very predictable. Similarly, at the other end, the GMFCS 4s and 5s have a very different set of problems than the 1s and 2s. These are the children who we're doing the hip reconstructions on, aligning the lower limbs for transfers and seating, and scoliosis surgery. The group where we spend a lot of time trying to figure out what to do is the GMFCS 3. This is, in a way, a transitional group. The developers of the GMFCS proposed it as a developmental trajectory. We clinicians frequently attempt to use it for more than that, which is not fully justified. However, we do, as I mentioned earlier, use it to guide clinical decision-making. In the GMFCS 3 level, there are clearly kids who, if we offer tone management, orthopedic surgery, orthoses, will maintain their ability to walk and possibly even improve it somewhat. Then there's other kids at the level 3 who, kind of regardless of what you do, the gait pattern is not going to change dramatically. And I've spent a good part of my career trying to sort out how to separate a GMFCS 3A, who should have orthopedic surgery, from a 3B, who shouldn't. We've looked at weight to strength ratios. We've looked at the ability to increase the speed of your walking and run, but more work needs to be done to sort out and guide clinical decision-making at the GMFCS 3 level. A classification scheme that we use in the motion lab and in our clinical research that you may not hear that much about is the Functional Mobility Scale, or FMS. The FMS has 6 levels, and the higher the number, the greater the function, the better the function. So it's a little bit confusing because it's not consistent with the GMFCS. This tool basically is a type of a patient or parent reported tool. And we basically ask, how does the child walk at the 5-meter distance, the 50-meter distance, and the 500-meter distance? And the child is given a score of 1 to 6 at each of those. So the highest functional level would be an FMS of 666. As seemingly simple as this test is, it has been extensively studied, and its psychometrics are quite robust. It's sensitive to change over time and following most of our interventions. So it's a very good tool and something that all of us use. All right, let's move on to the motor system. Here we're talking about the muscles, and we recognize that the muscles are growing and developing in children. The image to the upper left, the muscles are the round structures, and the black bars are the skeleton. So we have an agonist to the left and an antagonist to the right. In a normal neurological setting, there is coordinated growth of the skeleton and the muscles, and the agonist and the antagonist. In the lower left, we have the spastic agonist on the left and the inhibited antagonist on the right. And with growth, we get an imbalance where there is actual functional shortening of the muscle tendon unit of the agonist and excessive length of the antagonist. This is simple. It's not always true, but frequently it is, and it's helpful in our understanding of how muscles change in kids with CP. Muscle deformity in children with CP is initially dynamic. That means when the child is fully at rest, the length of the muscle tendon unit is typical. However, over time, we develop fixed anatomical shortening of the muscle tendon unit. We call that myostatic deformities. So muscle deformity in children with CP is sequential and it's progressive. Children with CP also have significant weakness relative to age-matched peers. Part of this, we've learned, is due to disuse atrophy. And in the last 20 years, it's become pretty clear that strength training for children with CP can be of benefit. Before that, it was thought that strength training would exacerbate spasticity. But clearly, strength training has been shown to improve gait function. And in an ideal setting with adequate resources, we would be taking advantage of this by offering significant prehabilitation before our aggressive interventions. Let's move on to the structural system. Now we're talking about the skeleton. It's also growing and developing, and we're all familiar with how the physis works. The physis responds to applied forces. We are taught that compression tends to slow down longitudinal growth, and tension or distraction speeds it up. That's reasonable, but it's simplistic. And it turns out there's a physiologic window for both of those applied forces that will actually speed up growth. And outside of that window, both of them will slow down growth. Anyway, why do we care? Well, in children with CP, abnormal gait leads to abnormal loading, and that disrupts skeletal growth. So the X-ray to the lower right here, we see a child with bilateral or diplegic CP and a flat foot. If we limit our analysis to the coronal plane, the ground reaction force is translated laterally relative to the ankle joint center. That results in excessive compressive forces on the lateral part of the distal tibial growth plate, which will result in ankle valgus deformity. So many of the skeletal deformities that we see in kids with CP are a consequence of abnormal growth that's due to abnormal loading. So like the muscles, skeletal deformity in children with CP is sequential. It progresses over time. Why do we care? Well, in the normal gait talk, we recognized that the muscle's job during gait is to generate a moment. And that moment is the product of the muscle's ability to generate force times the distance about which it is applied. Skeletal malalignment decreases the distance or lever arm available to the muscle, putting it at a mechanical disadvantage to do its job, which is to generate a moment. The rationale for all of the skeletal surgeries that we do for children with CP is to restore normal alignment, which restores the lever arm, which puts the muscle in as good a mechanical circumstance as possible to do its job. So on the left, we see a child at age 3 with bilateral CP who is walking on her toes. Her feet look pretty good relative to foot shape. She's just on her toes from tight plantar flexors. By age 8, the child may be walking with their feet flat on the floor, but look at how they got there. The heel cords are still tight, the hind feet are in valgus, the arches are collapsed, and the forefeet are clearly pronated. So at age 3, the X-ray may look like what you see on the left. The skeletal alignment is reasonable. It's a soft tissue problem. By age 8, we now have significant skeletal malalignments in addition to the soft tissue problem. So ideally, we would intervene with the soft tissues before we develop skeletal malalignments. However, it's clear that if we intervene too early with the soft tissues, that there will be recurrence with growth, and nothing in life is free. We damage the muscle tendon unit every time we lengthen it. So there's clearly a sweet spot where we are dealing with soft tissue issues in the face of minimal skeletal malalignments. And that is somewhere probably between 7 and 10 years of age. There are other strategies for dealing with this situation: more aggressive tone management by oral medications or intrathecally delivered medications, or selective dorsal rhizotomy at certain centers. The centers that support that approach offer those procedures early, believe that they can get control of the soft tissues without cutting them. And if there are subsequent skeletal surgeries, but avoid the soft tissue surgeries. Conceptually, it's cool. It doesn't really always work out that way. So in the normal gait talk, we recognize the importance of the ankle plantar flexors and terminal stance, motor number 1. And here's what's happening. So in third rocker, the center of rotation is at the level of the MTP joint. There's an externally applied force, the ground reaction force, at a certain distance from the joint center. That has to be matched by an internally generated force by the ankle plantar flexors applied at a different distance. And all of that works to generate that large internal plantar flexor moment and ankle power generation. So again, we restore skeletal alignment to restore the lever arm to give the muscle the best chance to do its job, which is generate the moment. So another example of this visually, the subject here is walking from the floor towards the ceiling. And this is the ankle joint center. Here's the knee axis, and here's their line of progression. When we get to third rocker, if the foot is well aligned, the moment arm available for the ankle plantar flexors is D, distance D. If we have an external foot progression angle because of a broken down foot, or external tibial torsion, or diminished femoral anteversion, or external pelvic rotation, whatever it may be, the greater the external foot progression angle, the smaller the distance available for the ankle plantar flexors at that critical third rocker. So we see this problem at the hip in the GMFCS 1 and 2. Fortunately, subluxation and dislocation is relatively unusual. However, persistent transverse plane malalignments do occur. And what I'm talking about is increased femoral anteversion, which is the relationship between the femoral neck proximally and the femoral condyles distally. So if we limit our analysis to the coronal plane, why do we care about anteversion? Well, if everything else stays the same and you have anteversion, that tends to move the trochanter posteriorly, and in the coronal plane, somewhat medially. So the hip abductors insert on the greater trochanter. The trochanter is a certain distance from the hip joint center. And as I've just told you, with anteversion, that moment arm in the coronal plane is diminished. Kids with CP figure that out and internally rotate their hip when they walk to bring the trochanter forward and lateral to restore the moment arm. So in a situation where there's increased anteversion and the child is walking with their hip internally rotated, if we surgically correct the anteversion, they no longer need to internally rotate their hip while they're walking. And that's common operation for us to do. You may be thinking, wow, this is a really simplistic analysis, one plane of a complicated three-dimensional joint. And I would agree. However, we've been using that for clinical decision-making for many years now, and there's literature from all over the world that confirms that you can correct dynamic internal hip rotation in the face of increased anteversion by surgically correcting the anteversion. When we talked about normal gait, we recognized that it was about getting from one place to the other. It required stability in stance, clearance and swing, effective phase shifts from stance to swing and swing to stance. And all of this has to happen in a relatively energy efficient fashion. Let's see how all of these are disrupted in kids with CP. Children with CP have decreased velocity relative to age-matched peers. They have decreased stride length and variable cadence. When a typical subject seeks to increase their speed, we typically increase our stride length and then our cadence. It's not always so in kids with CP. The literature is a little bit inconsistent on this, but in many cases, they choose to increase cadence, preferentially over stride length. And think about that. If they've got spasticity or muscles that are too short or they have poor balance, it would be easier to increase your cadence than your stride length. But anyway, that's presumably less than perfectly energy efficient. Let's consider stability and stance. We recognize that early in stance during the first rocker loading response, that there's shock absorption going on. In the plots that I'm going to show you, the typical is in blue, our hypothetical patient is in yellow, and we see that in children with CP, they lose heel strike at initial contact, which disrupts first rocker, which is what you see at the ankle plot on the bottom, and their knee is excessively flexed, which is what you see at the knee plot on the top. So this combination basically makes it impossible to perform shock absorption in loading response. We talked about stability in stance, particularly in mid-stance. This is compromised by foot segmental malalignments. So here's a child with a flat foot due to a tight heel cord, then a midfoot break, and we can see that there is excessive loading of the medial part of the midfoot. That part of the foot was not designed to be loaded, so there will be development of calluses and ultimately pain, which can compromise stability and gait. We talked about clearance and swing, which requires a co-activations and coordinated limb segment movements between the hip, knee, and ankle. In children with CP, they tend to have delayed and diminished peak knee flexion and swing, that's the plot on the top, and increased ankle plantar flexion, which is the plot on the bottom. Both of these decrease the normal limb shortening that occurs in swing, so it's common for kids to have impaired swing face clearance or a toe drag. Effective phase shifts, when we consider the phase shift from stance to swing, motor number one, the ankle plantar flexors frequently are compromised due to myostatic deformity and foot segmental malalignments. And as a consequence, they have a decreased internal plantar flexor moment, which is what we see on the top, and decreased power generation. So motor number one is compromised. The ability to go from stance to swing is compromised. Remember, to go from swing to stance, the limb has to be perfectly positioned to achieve a heel strike at the next upcoming initial contact. Children with CP frequently have increased knee flexion at the end of swing. That's the plot on the top. That's due to tight hamstrings. They frequently have increased ankle plantar flexion at the end of swing. That's the plot on the bottom. This may be due to tight ankle plantar flexors or inhibited ankle dorsiflexor function. Either way, with this alignment at the end of swing, it's impossible to get a heel loose first rocker. Energy efficiency, as measured by Inman, he focused on mechanical work, specifically the excursion of the body's center of mass. These days, we're able to do assessments of physiologic work through energetic analysis. I told you that these two are probably tightly coupled in typical gait. I think they may be uncoupled in CP because of the complex movement disorders, where spasticity, for instance, disrupts the relationship between mechanical work and physiologic work. That's a topic of debate in the field. Inman's classic JBJS article, he illustrated the excursion of the body's center of mass and how it was dampened using his compass gait. All of the elements that serve to dampen the excursion of the body's center of mass may be disrupted in children with CP. We discussed the concept of active versus passive stabilization subphases, with loading response being an active subphase where a lot of muscle activity is required to balance out the externally applied ground reaction force, and mid-stance being a relatively passive subphase where the location of the ground reaction force relative to the joint centers is such that only one muscle group is active. We mentioned that all things being equal, you like to minimize your time in active subphases and maximize your time in passive subphases for efficiency. And it turns out all of this is disrupted in kids with CP. Here's a child in crouch gait, which means their knee is flexed throughout stance phase. The ground reaction force is falling behind the knee joint center. Throughout stance phase, the knee is never offloaded. So you see the increased knee flexion in the top plot and the increased internal knee extensor moment. The quads are firing all the time here. And obviously this has energy cost. So we try through a systematic approach, relying very heavily on quantitative gait analysis to sort all of this out. Our decision-making is based on what we call a diagnostic matrix, which involves the integration of data from a variety of domains: the clinical history, the physical exam, diagnostic imaging, gait analysis, and finally the examination under anesthesia, where we have our best ability to determine how much of the muscle's deformity is dynamic or static, because the anesthetic agent basically disconnects the upper brain from the lower brain, and your physical exam now is not compromised by spasticity. It's all assessment of muscle tendon unit shortening. The modern approach to dealing with these problems is called single event multi-level surgery, or just multi-level surgery. It involves doing simultaneous skeletal and soft tissue surgeries, and to get the best result requires aggressive rehabilitation. This may seem like, oh yeah, this is how we do it because that's what you guys see. Over my 32 years of doing this, we didn't start out this way. So it's a fairly recent development, and we have a lot more to learn about it. We get together weekly to go over the gait data and come up with a specific plan of care for that child based on their data set, a form of biomechanically based precision medicine. This occurs at this hospital Friday afternoons. I've seen a few of you here. You're all welcome to come if your schedules permit. So in these sessions, what we do is look to recognize common gait patterns by performing a multi-level analysis, segmental assessment, and classifying gait deviations. And we focus our treatment interventions on those deviations that are related to functional deficits. So let me share with you how we classify gait deviations. It's a three-tiered system. First are the primary deficits or deviations. These are related to the underlying spasticity or movement disorder. So directly related to the CNS injury. Secondary deficits or deviations are related to disruptions that occur during growth and development of the musculoskeletal system. Examples here would be muscle contractures, so myostatic deformities, and skeletal malalignments. Tertiary deficits or deviations are coping mechanisms for primary or secondary problems, and we subdivide those into those that are pathologic, which means that in some way we think they are harmful or not sustainable. Knee hyperextension in stance phase would be an example of one that we think is not an acceptable tertiary deviation. Others, though, are clearly just compensatory. They're deemed helpful and are sustainable, in which case we embrace those and we don't offer treatments to correct those problems. So let's use the stick figure here to try to flesh this out, if you will. So here we're going to focus on the limits in black, normal alignment in mid stance. When everything is properly aligned at the ankle, the ground reaction force is located where it should be relative to the joint centers above. If we have excessive ankle plantar flexion and it's due to spasticity, we would consider it a primary deviation. If it is due to a fixed shortening of the ankle plantar flexors, then that plantar flexion would be considered a secondary deviation. Either way, if it's primary or secondary and nothing else changes, the ground reaction force is moved anteriorly. It's in front of the knee joint center, creating an external knee extensor moment, and the consequence is knee hyperextension. Knee hyperextension would be an example of a tertiary deviation. It's a compensation, but again, it's not one that we think holds up over a long time, primarily due to our experience treating polio patients. Now, what might a patient do to try to deal with the situation? Whenever I ask you that, or you're thinking about that, what you should be thinking is, how could they change their body alignment to bring the ground reaction force closer to the joint centers? So in this case, the subject might choose to tilt their trunk posteriorly, which indeed would bring the ground reaction force closer to the knee joint center. This would be another tertiary deviation, and we don't really think it's very harmful, so we would embrace it. Let's go in the other direction and start here with our typical alignment. If we have excessive ankle dorsiflexion in stance because of weakness, we would consider that related to the CNS problem and call it a primary deviation. If we have excessive ankle dorsiflexion due to a midfoot break related to a flat foot, we would consider this functional equivalent of increased ankle dorsiflexion to be a secondary deviation. Either way, if it's primary or secondary and nothing else changes upstream, this serves to move the ground reaction force behind the knee joint center, creating an external knee flexor moment, and we have increased knee flexion. In this case, the increased knee flexion would be an example of a tertiary deviation, and we recognize this as not being good. It results in biomechanical overload of the extensor mechanism, pain, and ultimately you can't walk. So what might an individual do to try to compensate for this situation? And again, you're thinking, how can they bring the ground reaction force closer to the joint center? Well, they might tilt their trunk forward, they might tilt their pelvis forward, they might flex their hip in mid-stance. All of these would indeed bring the ground reaction force closer to the knee joint center. And in the short run, these tertiary deficits or deviations can be effective, typically up to about the teenage years. And then after that, it's asking too much of your hip extensors and your low lumbar spine muscles. So it's not a long-term solution to increase knee flexion. So our interventions that address primary deficits or deviations are typically tone management through neurosurgery, so a rhizotomy or a baclofen pump, or pharmacologic, oral baclofen, or agents such as Botox. Interventions that address secondary deficits or deviations are the orthopedic surgeries that we do on the muscle, tendon units, and the bone, and the use of orthoses. And tertiary deficits or deviations will resolve spontaneously after we address the primary or secondary problem. Seems pretty obvious, doesn't it? Again, it was like 30 years of gait analysis to sort of sort this out and really determine which of these deficits fall into each of these levels. Okay, final topic is common gait patterns. We recognize 4 common gait patterns: jump, crouch, stiff, and recurve bottom. Although they focus on the knee, they actually are considering all of the joint segments, primarily in the sagittal plane. And here's a table from the classic article describing these. And you can see I'm on there. I was a fellow, and I sought to organize the brilliant thinking of my mentor, Dr. Sutherland. And it was a great experience for me to be part of this. Anyway, jump gait is characterized by increased knee flexion early in stance with recovery by mid-stance. The hip is typically flexed as well, and there's ankle plantar flexion. This is jump gait. Jump gait is very common. It's part of the natural history of how gait develops in children with CP, particularly those with diplegic or bilateral CP. And our challenge here is to figure out which of these levels have primary or secondary causes, and then perform simultaneous multi-level interventions to correct them. Here's an example: a 5-year-old girl with bilateral CP and jump gait. The spastic case that I showed you earlier was also jump gait. This child has more than just sagittal plane issues. She clearly has transverse plane issues as well. But anyway, the thing here is recognize jump gait, on your toes, knees bent. Next up is crouch gait. Crouch gait is characterized by increased knee flexion in stance phase. The magnitude of the flexion is generally greater than jump gait, and the knee is never offloaded, it never extends. Crouch gait is characterized by increased ankle dorsiflexion in stance, either true increased dorsiflexion or a broken down midfoot that results in the biomechanical equivalent of excessive ankle dorsiflexion. And the hip is typically flexed. When we compare crouch to jump, the principal difference is at the ankle. In jump, you're on your toes. In crouch, you're excessively dorsiflexed or your foot is broken down. And in my clinical experience, most of the gait deviations that we see at the hip in crouch gait are compensatory. Remember, we talked about moving your trunk forward to offload your knees. Crouch gait is also part of the natural history of gait. Children typically start out in jump. As they get older, if they're not treated, they get tightness at multiple levels and their foot breaks down. They get lever deficiency and they transition from jump to crouch. And again, early teens to late teens is where this usually happens. Unfortunately, crouch gait may also be iatrogenic. We see it following inappropriate single level surgery, usually ankle plantar flexor surgeries done in isolation. The treatment of true full-blown crouch is surgical and in some cases requires orthotic management, permanent orthotic management after the surgery. So here's an example, 15-year-old boy, bilateral CP. Two problems here. He underwent bilateral tendo-Achilles lengthenings, which were probably an overdose, overly aggressive surgery at age 4, which was too young. And 11 years later, this is his gait. So this is a crouch gait. This is a complex one where in addition to sagittal plane issues, he has transverse plane issues. Look at those external foot progression angles. Now, this is the kind of kid who we can help. He had the wrong surgery, but it was underdone instead of overdone in terms of too much stuff. He's light, he's strong, and he has good motor control. So you can have dramatic improvements in somebody like this. The third is the stiff gait, which focuses on swing and is characterized by delayed and diminished peak knee flexion in swing phase. Typically, the ankle is plantar flexed and the hip is flexed. The delayed knee flexion and the ankle plantar flexion compromise functional shortening, and we think that the hip flexion here is probably a compensation to try to help clear the limb in swing phase. Stiff gait may be part of the natural history of gait. It can be related to spasticity of the rectus femoris, in which case we have a surgery for it. Or it may be related to poor hip flexor function in the stance to swing interval. Remember in the normal gait talk, we discussed how what happens at the knee in swing is controlled by the hip. If it's related to poor hip function, there really is not a surgery we have that will improve stiff gait. Unfortunately, stiff gait may also be iatrogenic. We see it following isolated lengthening of the hamstring muscles where we failed to appreciate that the antagonist to the hamstrings, the rectus, actually has spasticity, which can be unmasked following surgery on the agonist or the hamstrings. Anyhow, if the stiff gait is due to problems with overactivity of the rectus femoris, we have good surgical treatments for that. It's fractional lengthening of the rectus femoris or rectus transfer from the front of the knee to the back of the knee, sewing it into the hamstrings, turning the rectus from a knee extensor to a knee flexor. Here's an example, 9-year-old girl, right unilateral or hemiplegic CP. She had a right tendo-Achilles lengthening and a medial hamstring lengthening. The mistake here was to not recognize the rectus, and she has a stiff knee gait. The knee should flex to 60 degrees and swing. Hers is maybe getting to 30, maybe. Fortunately, the literature shows that if you make this error in judgment, a subsequent rectus surgery can be effective in unlocking the knee in swing phase. However, you prefer obviously not to be doing multiple surgeries, but there is a bailout. The final gait pattern is called recurvatum gait. This is characterized by knee hyperextension in stance phase. It may be associated with increased ankle plantar flexion, and the hip may show rapid extension as well. Recurvatum gait may be part of the natural history of gait in children. It may be related to the plantar flexion knee extension couple. That means that, again, the ankle controls the knee in stance phase, so what's happening at the ankle is driving the knee. We see it in children at the GMFCS level 3 and above who use assistive devices. In almost all of those, the trunk tilts forward. That moves the ground reaction force in front of the knee joint center, creating an external knee extensor moment. That's why in pediatrics and CP, we use rear rolling walkers to try to get their trunk to be more upright. Whereas in adults, you'll hardly ever see a rear rolling walker. Finally, recurvatum gait may be related to the movement disorder, as I alluded to earlier. Children with more complex movement disorders may prefer to keep their knee in end range for stability and to increase proprioceptive feedback. Unfortunately, recurvatum gait may also be iatrogenic. We see it following excessive lengthening of the hamstrings. And almost always that means the medial and lateral hamstrings were lengthened. Here, you'll rarely, if ever, see us lengthen the lateral hamstrings in an ambulator. So here's an example, 9-year-old girl, right unilateral or hemiplegic CP, recurvatum gait due to ankle plantar flexion knee extension couple. Now. In this case, if we get control of the ankle, stretch casting, Botox, surgery, orthoses, we can anticipate that the knee deviation will correct. 12-year-old girl, mixed, so more complex movement, bilateral CP. She underwent bilateral medial and hamstring lengthenings at age 5. So a couple mistakes here. Failed to recognize the more complex movement disorder. Had overly aggressive, overdosed hamstring lengthenings, medial and lateral, and it was done too young. And here she is 7 years later, recurvatum gait. This is an insoluble problem. We've tried all sorts of transfers, orthoses. Basically, they need to get on an assistive device, a walker or crutches, to control what's going on here. So the best thing is to avoid it by not making those mistakes. So 4 patterns that are characterized by sagittal plane alignment at the hip, knee, and ankle. So I've attempted to show you a systematic approach to dealing with these complex patients and their complex gait disorders. Each child deserves an independent evaluation. What I've shared with you is a framework for analyzing their gait that is really based pretty heavily on physical exam, but most heavily on quantitative gait analysis. In the end, every child is a little bit different. That's what keeps this really interesting and challenging. And as I mentioned earlier, I like to think that we perform a type of biomechanically based precision medicine when we offer treatments to these children. Caring for kids with CP certainly is challenging, particularly in our healthcare system. This is what really brought me to Shriners so many years ago, because we're subsidized and allowed to do it the right way. It can be very, very rewarding work, though. And if you guys join any of the 3 of us in clinic, you'll see some pre and posts that are really dramatic. And for as long as we've been caring for kids with CP, there's still so much that we don't know. So it's a great field to make academic contributions to the body of knowledge. So questions or comments?
Go back to the graph that you have from your paper, the F and the flexion, what is the letters for again?
Yeah, so F is flexion, and the arrow up is increased. So at jump gait, it's increased early in stance. And as I mentioned, it's variable. Usually they recover by mid-stance. This terminology here, initial double support, single support, second double support, was the terminology that we were using at the time. Okay. There's been work since this, looking at gait patterns that was built off of this, that would be where you would want to start to get what I shared with you is up to date, but you would not go back to this paper to learn about this. The authors on the one that I'm thinking about are Rhoda, R-O-D-D-A, and Graham, and they were published in British JBJS. And yeah, there are two of them, one on gait patterns in unilateral CP and one on gait patterns in bilateral CP. And what's missing here is really emphasizing ankle and hip, which we actually did in the paper, but not in this table. And there's no coronal or transverse plane. However, this is the foundation for what came after. Good question. Any other questions or comments? Again, this can be kind of overwhelming. I'm really glad that we were able to do this the week after the normal gait because the two are linked. These are available in the education file. And if you have a deeper interest, going back to these, I hope will be helpful for you. So with that, I'll thank you for your time and attention this morning. You're welcome.